Okay, very good morning to all the participants of the BUU Urological Update 2021. My name is Mr. Roger Anthony Edie, and today I'll be going through with you together regarding a common topic which normally patient can present with to our outpatient clinics. So in today's talk, I'll be generally, in a nutshell, I'll be talking about the diagnostic pathway, clinical tools, management pathway, as well as treatment options. And towards the end of my talk, we'll be opening the session for questions and answers. Simply speaking, when a patient presents to you in a clinic with a complaint of difficulty passing urine, in simple terms, can be divided into either a functional or neurological problem versus anatomical problems. Anatomical problems specifically means that it can be either to any obstruction in the lower urinary tract involving the urethra, namely strictures, bladder neck, bladder outlet, namely prostate, as well as can be either due to tumor or bladder stones. Meanwhile, neurological or functional, as the term implies, is due to either any lesions in the neurological pathway, or it can be due to functional issues once all the neurological problems and anatomical problems has been excluded. So when a patient comes to you complaining that he has difficulty passing urine, of course, you need to start by taking further details regarding the history. And on top of that particular symptoms, you need to exclude any accompanying symptoms. And these symptoms can be roughly divided into obstructive or irritative or filling symptoms. And based on what this slide shows, it can be due to either voiding or storage. So what are the clinical tools available for us to assess this patient in clinic? So I'll start with an IPSS questionnaire, which stands for Internet Prostatic Symptom Scores, in which all the patient's symptoms are graded according to frequency, as well as severity. And in addition to that, the impact on the patient's quality of life. In addition to that, our assessments or clinical tools available for us includes a frequency volume chart, or what we know as a bladder diary, urine analysis, and if your clinic has an ultrasound, why not just use it and scan the bladder for any bladder stones, tumors, any abnormality, as well as you can use the ultrasound to measure the prostate gland size. We'll start with anatomical causes for difficulty in passing urine. And of course, I will start with the most commonest cause, which is benign prostatic enlargement. As one age older, as you can see, the prevalence in the community increases. Up to 40% of men between the age of 70 to 79 years of age will have a benign prostatic enlargement with or without severe or bothersome bloods. Meanwhile, for urogenic bladder, as the name implies, it is due to a difficulty of bladder emptying due to a lesion or pathology within the neurological system, and this can be divided into whether the nerves of the brain or the spinal cords are affected, or if it involves the peripheral nerves. In this case, the most commonest one will be a diabetic neuropathy. This diagram shows the micturition pathway in which our micturition cycle is controlled primarily by our cerebral cortex, pontine micturition center, and supported by our parasympathetic and sympathetic nerves via the action of the hypogastric as well as pelvic nerves as well. As you know, our micturition pathway are a very intricately coordinated process and involves the coordination between these two regions. This slide shows the correlation between the neurological lesions, the location of it, as well as the expected or anticipated symptoms that the patient might have. So in this case, if the patient comes to you complaining, doctor, I have difficulty passing urine, if you have excluded any potential or possible anatomical problems, then you would try to exclude any neurological lesions within the sacral or infrasacral region itself. So back to the treatment for lower tract symptoms, and in this case, I'm focusing more on the benign prostatic enlargement. The treatment can be divided into conservative or watchful waiting, medical therapy, or surgical options. Watchful waitings, as the name implies, involves educating the patient, modification of lifestyle, as well as preventing or avoiding any precipitant factors which can contribute to the patient's symptoms. While medical therapy involves the usage of alpha blockers, 5-alpha reductase inhibitors, as well as in certain select patients, PDE5 inhibitors. Alpha blockers, the minimal clinical effect is seen within hours to days, and what we expect when we start the patients on alpha blockers is a reduction in the IPSS score of up to 30 to 40%. However, as a point of note, if the patient is scheduled for any cataract surgery, these patients should not be on the alpha blockers as it can lead to a floppy iris syndrome. 5-alpha reductase inhibitors. Commonest ones that we prescribe to patients include finasteride and dutasteride. It inhibits the conversion of testosterone to dihydrotestosterone, and the end effects, it leads to a reduction in the volume of the prostate by up to 18 to 28%. And nowadays, based on more recent evidence, there's a propensity to start the combination therapy earlier in patients with moderate to severe LUTS or benign prostatic hypertrophy. The justification or evidence for combination therapy and its long-term efficacy is backed by these two landmark studies, namely the MTOP study as well as the COMBAT studies. And these slides show the details of the papers as well as the outcome. As you can see, starting the combination therapy earlier will lead to a reduction in the incidence of AUR or BPH-related surgery, AUR episodes, as well as the clinical progression. And this slide reinforces the point that I was making just now. However, it should be known that each of the component of the combination therapy has its advantages as well as disadvantages as well. As you can see, the combination therapy ticks all of the boxes and complements each other very well. This, if the symptoms are coupled with any other symptoms as well, for example, frequency or urgencies, then additional treatments such as antimuscarinics or a beta-3 agonist can be added on later on. So these management pathway are taken from the European Association of Urology guideline. And the key that I wish to highlight here is whether the symptoms are bothersome for the patient. And as you go down to the management pathway, as you can see, it always starts with the conservative, and it's really bothersome to the patient and impairs or impacts on the quality of life, then you have either option of medical therapy or surgical therapy. So surgical options includes a transurethral resection of the prostate, bipolar or laser enucleation, mammocath, urolith, rasum, or a prostatectomy. A mammocath, urolith, or rasum, is considered an office procedure and can be done under local anesthesia. So lastly, when to refer these patients to a specialist clinic for further assessment if the symptoms are not responding to initial drug therapy, if they are experiencing recurrent urinary retention, recurrent urinary tract infections, or if you suspect if they are harboring any possibility of urological cancer, for instance, visible hematuria, raised PSA level, then they would ideally be referred to a specialist clinic for a further review. So I'm open to any more questions. Uh, I'll leave it to the chair to continue on with the next presentation.